introduce myself again. Suffice to say, I'm a retired orthopedic PA. I've deployed to 5 continents, and I was there for Fallujah. I've seen a little bit of trauma. This is, a 40-minute brief overview to austere medicine and trauma. It's something that's near and dear to my heart, not just from doing it, but I've enjoyed being a member of a research board for the last 15 years on austere medicine. And so it's something that's near and dear to my heart. When we approach austere medicine, really what we're looking at is a couple of philosophy differences in the medicine that we're used to. We try to get it, as high a percentage of correct diagnoses and correct treatments as possible. We expend incredible amounts of energy to do so, to provide really high quality care that we have available in America and other first world countries. That being said, the system is not perfect, of course, and there's some refreshing aspects of austere care to include no computerized charting. However, what we try to look at when we're approaching this is, how can I do the most good with the simplest interventions and the simplest resources? And so, a good starting point is to say, one of the surgeons in a Bangladesh hospital was explaining to me that we have 30% infection rates on our C-sections. And I was, he saw the look of shock on my face. 30% infection rates. That's horrible. This is a devastating infection to have. And he said, no, you don't understand. People die here from a lack of a surgery, not from a lack of a quality surgery. The mortality rate for not having a surgery at all is so high, it's well over 95%. So, we're saving 70%. And so that's the goal here. It's amazing what you can do. And so the key is to apply the best science that you can come up with and try to affect a solution. Another good example of that would be, what's the difference in traumatic wounds that are managed with somebody that has, sterile gloves versus clean gloves versus well-washed hands? Well, there's no difference in outcome. And so, it's interesting things that can be discovered along this journey. The other thing I like to do when I approach this is to say, what are my most likely injuries? What are my most likely illnesses? What am I going to encounter? And the things that we evaluate as we're going to run a mission set overseas or a mission set right here at home is, what are the participants? Who are the people that I'm covering down on? How many are there? What's the state of their health? What pre-existing conditions do they have? What are their capabilities? What activities do we expect to be doing? So, grid down, we may be chopping a lot of wood, which we may or may not do prior to that type of an event. What environmental differences will occur, specifically, open sewers and things like that. So what changes will happen there? Also, so we try to develop a list of the top 10 things that we can experience. Then also the other thing we need to consider is what other resources are available. There's no way in a 40-minute class that I can make you an expert in all of these different topics. I can point you in different directions, but that's essentially impossible. So look around your community and say, what other resources are available? What physicians do I know? Now, if we have a significant pandemic, like Kenneth talked about, it may be that healthcare providers are very hard to come by. Many of them may get infected. What veterinarians do I know in my community? What dentists are available? And so people with basic skills that work in any healthcare sector may be advantageous to call upon to assist with coming up with solutions. And so that's part of that overall assessment as we go into it is how do we approach that. Trauma is a really big event in these environments. Injuries are common, unfortunately, and especially as society degenerates, injuries become significant. So I wanted to spend some time today talking about that. I wanted to spend some time talking about definitive wound care. how not just to do the first aid, but how to do the secondary and tertiary aid for large wounds and significant wounds, and just kind of overview some of those things. Obviously, this is a very broad area, and I'm happy to field any questions, but those are the main areas that I'm going to try to cover tonight or today. So the first thing I want to talk about is an individual first aid kit. Actually, scratch that. The first thing I want to talk about is injury prevention. And I know Erik mentioned this. I just want to second it. He's absolutely correct. Look at the bits and pieces of your body that stick out and interface with the environment and cover and protect them. Good shoes, good gloves, good eye protection, and something on your head that's going to protect you from getting bumped. You'll go a very long way towards injury protection if you can just cover those things. That's where most of the problems happen in a work type environment. In a penetrating trauma environment where people are throwing rocks at each other really, really fast, body armor is a very good thing. Cover up the important stuff. So an individual first aid kit is a light, small, trauma-focused kit. And what's really important when you're setting this up is to not mix it up with the boo-boo kit. This doesn't have Band-Aids in it. This doesn't have Tylenol in it, potentially. Maybe it does. There's a place for that, but it typically doesn't. And it doesn't have, cold and flu remedies. This is a trauma-focused kit. When you're dealing with a trauma and you need to get an arterial bleed managed, and you've got 60 seconds potentially to get that done, you don't want to be fumbling around other things. So it's light, it's very focused on one specific task. In a high threat environment or in an environment where there's increased risk, this is the type of thing you carry on your person. It becomes part of your everyday carry. There's multiple types or styles out there. This is an example of an ankle first aid kit. This one rides on my left ankle. It has a tourniquet. We're going to talk in more detail about these different components. This is the one that I carry. It has a tourniquet, needle decompression needle, a little tiny short Sharpie marker. It's got a hemostatic gauze. I'm
sorry to interrupt you, but we aren't seeing anything you're showing. For some reason, your video is on an extreme lag right now.
Oh, shoot. Let's see if we can fix
it. Is there something else that's using internet in your home right now that you could turn off?
Let's go see.
Is there anybody else on a computer or somebody else? Because nothing is showing up.
And see what's going on there. That could be the case. Suffice to say, it's an ankle kit that carries various items, and it rides on my left ankle. And it's something that the reason I carry it there is because it's readily accessible when I'm kneeling down, and it's out of the way when I'm doing other things. Other places to carry a first aid kit that make a lot of sense would be like the visor of your car would be a place to place something like that. So my kit has chest seals in it also, and then I have something that's a little more exotic in my kit because my skill set, but it's actually a Foley catheter with a syringe for managing deep penetrating arterial bleeds like in necks and things like that. And so let's go over some of these things in a little bit more detail, and hopefully this video will kick on. Let me know if it does so that I can show some things. We'll come back to the video here if I can get that to resolve. So tourniquets. So I want you to envision your body, and tourniquets are appropriate for the extremities. And what we do is if you have a significant, they're going to tell me if it turns on. And so if you have a significant bleed on an extremity, you're going to apply a tourniquet. Many of us learned at one point in time that once you put a tourniquet on, you never remove it. That's false. Once you put a tourniquet on, you're going to lose the limb. That's false. A tourniquet is a last resort. Apply everything else first. In austere settings, the best transfusion for this patient is keeping their own blood in their body, because other options aren't necessarily available. So a rapid application of a tourniquet can be not only life-saving, but a very good idea to stem bleeding in extremities. Obviously, this doesn't work on the head or on the torso. And so a tourniquet is your first application. You can then follow up with a pressure dressing, which we're going to talk about, and wound packing and things like that. And we'll talk about removal of tourniquets. On junctional areas, that's basically like armpits and the areas of the shoulder that aren't the actual chest cavity. But those areas, we use wound packing. And we're going to go over how to do that once I get video up and running here. And we try to pack that area tightly and compress gauze into those sites to try to stop the bleeding, and we apply a pressure dressing. And then the last section is the torso itself, the chest and the abdomen. And we think of that as seal the box. That's areas where we don't want leaks. We don't want intestines falling out, and we don't want air moving in and out of the side of your chest, because that's not helping. And so if you can think of it in terms of tourniquet, wound packing, and seal the box as we come towards the core, then that's a beneficial approach. We're still struggling with video, yes?
Yep, we only see you about every 30 seconds.
Okay. Boy, that's going to make this problematic, isn't it?
Potentially try streaming by phone.
Okay. Yeah, try to pull up a phone stream.
Let's get in, actually.
Okay, so I'm going to keep talking. I'm going to keep talking while we're working on that. And so we're going to do a lot of demo. We're going to come back and do a lot of demo all at once here. So sorry about the sequence here. Gauze. Let's talk about gauze a little bit. Kerlix rolls are your basic tool. It's a 4-inch, really fluffy roll gauze of just a fluffy material that comes in a roll. And that's your basic universal dressing. When I look at these pre-prepared first aid kits, they're full of 2-inch by 2-inch gauze and 4-inch by 4-inch gauze and specialty eye patches and all kinds of things like that. Doesn't make any sense. It makes logistics very difficult. You never have the right thing. Whereas a roll of Kerlix is universal. If I need a 4x4, I roll off some sections of Kerlix and then I cut it off. If I need a 2x2, I roll off some section and cut it off. But wounds don't come in squares. So I've got something that I can pack or change the shape of to fit the shape of the wound very effectively. And so having Kerlix rolls, I think of that as the basic, a number one building block item to have in austere medicine and managing wounds. It's just universal. Hemostatic gauze has been talked about a lot. And so the most important thing with using gauze is to pack it correctly and to pack it into place right on the bleed site. Hemostatic gauze is like combat gauze or Celox or things like that, can give you about a 20.
Sorry.
What we're echoing. Oh, let me.
Well, I'm trying to.
Is that muted?
It's not allowing me to mute. Please mute that one.
Stand by.
We're in as a participant, and it's not allowing us to unmute ourselves and giving a mic Swartz. There, now that should work.
We're up and running. Can you guys see me?
Yes, that's much better.
Okay, video's up. Okay, great. So I'm going to backtrack and start showing stuff here. This is the ankle first aid kit. It basically Velcros around my ankle and hides under my pant leg, tourniquet, combat gauze, and some chest seals. So it's just some basic tools so that if I'm, having to take care of the fight and manage the injury, I've got this readily available. Again, typically on my left ankle because I'm right-handed, just the way I typically kneel down. The tourniquets This is the cat tourniquet. This is the one that is the most commonly used. And this is the one that I would, recommend for a lot of people, not because it's the best tourniquet, because it's not. It's got some failure points and it's got some problems, but because it's so universally used, the CAT or Combat Action Tourniquet from North American Rescue is ubiquitous, and people know how to use this wherever you go. The number one problem with putting a CAT tourniquet on is people don't get them tight enough to start with, and the number two problem is not tightening the windlass down tight enough. The number three problem is not having a second tourniquet. There's a failure rate on these tourniquets in terms of being able to stop blood flow. If you put one on and it doesn't stop the blood flow, then put a second one on next to it, by all means. The ankle first aid kits are all over eBay and Amazon. Just look up IFAC ankle and you'll be able to find that. Another version of this is made by Recon Medical. And that's the one I'm going to recommend that actually the group buy. The Recon Medical Tourniquet is a superior build. It has an aluminum windlass. It has Kevlar stitching on it, and it's significantly more robust. It has not gone through the same testing that the CAT tourniquet has, but it's basically the same design, just built a little bit more stout, and it's about half the price, even a little less than half the price. And so Recon Medical, those are available on Amazon. And that's a really good tourniquet to carry. Again, same function as the CAT, so there's no learning curve there. It's great. So Jen, with your, you want me to throw a tourniquet on you real quick? All right. So first we slide it right up her arm, grab the tail and cinch it up.
And Mike, does it matter where on the arm you put it?
So you're going to see different things in terms of where to put it on the arm. I like high and tight, right up at the top, because I get very good vascular compression up top. The vessels are very well exposed, and it's also a no-brainer. It's not going to slip off or fall off. It's got a muscle in the way, and I don't have to think about this when it's dark and it's cold and I'm moving fast. I can just throw it on real quick. Later down the road, we'll talk about adjusting things. We can move it down closer to the wound, 3 to 4 inches above the wound. But when it's dark and it's cold and it's wet and we're going quick, just throw it up top, because you may miss a higher injury in that initial inspection. And then basically we're going to crank this on. So for training purposes, I'm going to have you do this and make a fist a few times up top. And this is just pumping the blood out of her arm. You're fine. There you go. Now hold that fist real tight. There you go. We're just pumping the blood out of her arm just so you can see the effect here. Isn't that enjoyable? So tourniquets hurt. They're not benign. One more crank, I think. Yeah.
Maybe
I'd
rather die.
So that hooks into the little hook. We put a little piece of Velcro across the top. Go ahead and release that. And you can see, just looking at the color of her skin, you can see that we've got a good tourniquet in place. I'm also checking her pulse right here on the wrist, and there is no palpable pulse. You want to find the pulse, you find the little bony landmark of the wrist bone, and roll just a little bit to the inside, and that's usually where it's set. So she's, pale. We check the wound and make sure there's no bleeding. And if there's no bleeding, then we've applied a correct tourniquet. If we need to tighten it up, we can, or if we need to apply a second one next to it, we can. The overall sequence of things is once we throw that tourniquet on, then we're going to go ahead and check everything else out, make sure she's doing okay. Otherwise, get off the X. That is to say, get away from the dangerous thing that caused the problem to start with. And then we're going to come back and we're going to pack that wound, and we're going to try to take down the tourniquet. We'll talk about those protocols again here in a sec. And so that's the quick application of that tourniquet. There's an improvised tourniquet that we can use. So Jen, if you want to film for me, I'm going to cut this up.
Oh.
Yeah, or angle that down a little bit. So what I've got here is basically a Portland Fire t-shirt, surplus t-shirts from the fire department. And so what I'm going to do is put a nick in the shirt. And you can see how wide that is. That's pretty important. It's a little wider than my hand. And I'm just going to tear this thing off and get rid of the excess. I'm going to take this t-shirt here. Everybody can see what I'm doing, I hope. And I just cut it so that I have a long strip of material that while it looks like it's skinny, once I stretch it out, it's actually, you know, fairly wide. So come on over, Jen, I'll pick on you one more time. So what I'm going to do, actually, I'll put this on your forearm because
Sure.
it's just easier to show. I'm grabbing the midpoint of the tourniquet and I'm slipping it around your arm. I'm looping both ends through the loop. Okay. And I'm going to pull in opposite directions. And what I've created is 2-to-1 purchase here. This is going to pull on your skin a little bit. Sorry. Okay. And then I'm wrapping the tails around in opposite directions and pulling, adding more pressure. One wrap, just like the first part of your shoelace. Second wrap, pull it down tight. And I've got a tourniquet, no pulse. Okay, so it's just a very quick tied on tourniquet. If you wanted to add a windlass to this or a stick to rotate, you could, but it's really not necessary. And there's a lot more to this. It takes practice to be able to do these. You double 2 of these together to do a leg. But for purposes of today's presentation, I just wanted to show that you can create a tourniquet when you don't have one in your kit really quite quickly just by looping that knot right there. Okay, it's just a prusik, first part of a prusik there. Okay, all right. So you can make improvised tourniquets that are actually quite successful. The problem with most improvised tourniquets like belts and things like that people talk about is they don't work and they're notoriously unsuccessful. And so improvised tourniquets have had a bad rep. You got to build them correctly to actually have them work. Here's the Curlex rolls we talked about. Very simple thing. When you're spooling these off and packing wound, we typically pluck from the center just so you don't have this thing rolling in your hand and falling in the dirt. So Jen, if I can borrow your hand again, we'll angle that camera down all the way to the table. All right, so packing a wound, all right? So what she's done is she's got her hand set up like it's a wound. There's an open top and she's got her little finger part closed all the way at the bottom. And so when we're evaluating this wound, we want to find the arterial bleed, find that artery that's pumping. You can look and you can feel. I'm looping the biggest digit or the biggest, finger or thumb on my hand that will fit down that hole into the gauze. And then I'm pushing all the way down in here and I'm feeling. And in this case, I'm feeling for her little finger in a bleed. I'm feeling for the side of the bleed. And then what I'm going to do is pull a little excess material, grab it and shove it down the hole, alternating thumbs as I pack this hole right onto that bleed. And what I'm trying to generate is an upside down pyramid so that I've got a tiny little tip of material on the arterial bleed and the rest of it's just filling the hole as tight as I can get it. And the remainder I just pile right up on top and create a pressure dressing out of it. That same tie that I used for the tourniquet makes a really good pressure dressing tie. Just don't make it quite as tight. And you can actually squeeze and hold this in place. You want to apply pressure for at least 3 minutes, if not longer, when you're doing a technique like this to try to prevent that bleed from continuing and to try to help this thing clot up. Again, this is mostly used in armpits or those junctional areas, but this is also used on the extremities after the tourniquet's been applied.
Tourniquet.
Okay. So I'm going to pick on your arm one more time, and we're going to put the tourniquet on incorrectly. Okay. And so this is called a venous cuff. When you have your blood drawn and they put a little elastic band on you, that's what they're creating as a venous cuff. And I just want to show how different this looks from the actual tourniquet. Okay, so taking a look at her hand, if we look at the back of the hand, you'll see the veins starting to lift up on the back of the hand. And over time, her hand will turn red and swollen. It should not be red and swollen. It should be more of a pale, paler color. I may not even have it tight enough for a venous cuff here.
Yeah, they're popping a little bit, not as much.
They're popping a little bit, but not too much. So let's just get this to go here. There we go.
There it goes.
Yeah, there it's popping up. So that's what not tight enough looks like. And of course, you're going to evaluate the bleeding, and that's the definitive thing that you're going to look for. But these are other clues that you can look for as to, hey, that's just blocking the venous blood flow. That is to say, the arterial flow is coming in, but the venous blood is not coming back out. So again, focusing on a question here. A tourniquet is the first resort in austere medicine, is not the last resort. As we mentioned before, that's the first thing you want to throw on so the patient doesn't lose any more blood. So removing tourniquets, how do we take tourniquets off? So the first thing is, if you suspected it needed a tourniquet and you slap that thing on real quick, great, you got the tourniquet on and you've got good hemostasis, and you're going to evaluate several things. One, do I have good blood control for this bleed? Is it working? Two, is my patient stable? That is to say, are their vital signs stable? So normally when we teach this as a full day class, we do a full head to toe assessment, and we go through a lot more detail rather than this very focused thing that I'm doing today. And so we check their pulse. Is it too fast? Is it light and thready? Can I not feel a radial pulse? These are patients that don't have enough blood to be able to play with. You leave the tourniquet in place and don't mess with it. Do I have a stable environment? That is to say, if we're bouncing in a truck down the road, that's not the time to take the tourniquet off. Do I have a stable medic? That is to say, one person that can watch the patient, exclusively and monitor for a return of bleeding. If I have all those criteria, then I can take the tourniquet off after about 30 minutes. Now, tourniquets hurt. One of the other reasons for failure of tourniquets is that they hurt, and patients take them off themselves in spite of their bleeding issues, and so that's a concern. So you got to watch the patient as well and keep them safe. After about 30 minutes, you've got a lot of blood clotting done. You've got a good wound packing done. You've applied pressure to it, and then you can try taking the tourniquet down. That is to say, you leave it in place, but you loosen it and watch for bleeding closely and make sure they're doing okay. If they have bleeding, then you put it back up again, and that's what it's going to be until you get to more definitive care. And again, definitive care can be a real challenge in an austere environment, but we need to save this life. Okay, so we did venous cuff, we did the tourniquet, we did the Curlex rolls, combat gauze we talked about a little bit before we switched cameras. So hemostatic dressings are going to add about a 20% improvement to the performance of your wound packing in terms of slowing down bleeding. And so in a disaster environment or a penetrating trauma environment, I think they're very, very beneficial. If you're a hunter or you like to run a chainsaw out in the woods, boy, that's a really good idea to have a hemostatic gauze dressing. It's going to help improve your success rate if you had an accident. For general hiking and just general blunt trauma, I don't know that it's all that important. They do have a cost associated with them. The two that I recommend is the combat gauze, but also the Celox dressing has some advantages in terms of it also works when the patient's own blood clotting mechanisms are not working, which can happen in trauma. And so, if I were to pick what's the number one, it'd be Celox. So it's number two, combat gauze. Other people might disagree back and forth. It's a close tie there. And so that's that piece of this. In terms of chest injuries, the basic premise here is the air goes in and out and the blood goes around and around, right? So we want the blood to continue going around and around. We want the air to go in and out the correct hole. The airway is, about that big in an individual. And that's if we have a hole that's bigger than that in the side of the chest, air can preferentially move that way. And so the first and best seal for that is the patient's own hand. Have them put pressure on it while you're getting everything else ready. Typically they breathe out, you put their hand on it, they breathe in, and they're going to help expand that lung. You want to get a chest seal on there as quick as you can. All it is a big sticker. Okay. The best ones are vented. I've listed the brands on the handout. The Russell chest seal is the best, but it's about twice the price and probably not worth the difference. The close second is the Hyphen from North American Rescue. And they sell it in a twin pack for the entrance and exit wound. And that's the one I would recommend right there. You've got all kinds of other things that you can add in. There's other non-vented seals that are out there. I've watched the literature go back and forth between vented and non-vented. I'm going to suggest that the vented is the correct answer right now. But that, you know, if you have non-vented, you just got to watch the patient for air accumulation in their chest, which again goes beyond what I can teach in today's class. There's a technique called needle decompression, which I'm not going to cover today. It's just too much information for one very short class. And we typically do a dead tissue lab with that. That's to say we have you needle a dead pig, and then we let you see what's happening on the inside of the pig when we do that, so you can really learn the skill set. Somebody's asking about cayenne pepper, and it's just a flat no. That's the short answer. Sorry. I won't go into too much more detail there. You know, if you cut yourself shaving and you want to burn your face, cool. But for significant arterial bleeding, that's any powders, first off, are not mechanically going to stay put. They're just not going to stay there. And so, you know, for small venous bleeding, like a septic pencil type use, sure, if you want to use that, knock yourself out. But for this type of bleeding, not indicated. Okay, and then we're going to skip over the Foley catheter decompression techniques. Again, when we teach this as an all-day seminar, we can go over that. But suffice to say that it's very hard to compress things in the neck, and so we try to do it with a Foley catheter, inflating a balloon that puts pressure on that artery. I'm going to show a couple of other ways of putting on a neck dressing or awkward pressure dressings. Have a seat there. And so if I wanted to put a pressure dressing on the left side of Jen's neck over here, what I'm going to do is pack that wound and put the pressure on it. And then I'm going to bring her opposite arm up and over the top of her head. Okay. And then I'm going to take and put my pressure this way. So what I've done is I'm putting pressure right on the dressing, and I'm using her arm to protect the vessels on the opposite side, so she continues to get circulation to her head. And that's the way I can get a good pressure dressing on the neck. And there's several other techniques like that in different parts of the body that, again, we teach in the all-day class. But that's one for the neck that I just thought would be really beneficial to throw in there. How to get a pressure dressing on a neck without compressing a person too much. How are we doing on time? Somebody give me a time check here.
It's like you've got maybe 12 minutes.
Okay, we lost a little bit of time.
Stopping for
Okay.
probably soon.
Okay, definitive wound care. Let's go over that real quick. So basically in grid down environments or environments where we don't have access to great health care, we want to treat wounds open for the most part and let them heal from the bottom up. If we try to sew them together, we get a lot of infections. There's a time and a place to still sew wounds together, but it's really far and few between. Most of these things we're going to allow a little bit more scarring, and we're just going to let things heal up from the bottom. And that's basically, you know, that first wound packing we showed, we piled this thing in here really, really tight, and we pounded it in there to get hemostasis. And so if we're in a backpacking or outdoor setting, or even in our garage, and that's our definitive care. Once we get good hemostasis, we're going to turn around and get a clean packed wound dressing in place. I try to leave it in place for quite a while. That's say 2 to 4 hours, 12 hours is fine of a tightly packed wound. And then we want to get that out and start doing what's called wet to dry dressings. And we'll talk about how to do that. And so what we're going to do once we get this thing packed and tight is we're going to go boil some water. And so we're going to grab that water kit that we had earlier, and we're going to get this water boiling on the stove. All right. So put that on a fire, obviously loosen the lid and get some water boiling. The other thing I'm going to do with this is while I'm boiling that water, I'm going to take some more Kerlix gauze and I'm going to throw it in the water if I don't have sterile. If I have sterile Kerlix, I'm fine. But if I don't, and all I have is, say, t-shirt to work with, I'm going to boil that at the same time and try to get that good and clean as well. Now, you notice I'm using a knit material, not bed sheets, which are woven. Bed sheets or woven material tends to leave a lot of residue in the wound. So knit material like t-shirt is ideal. And then boil that up. And then by the time I get this boiled up and cooled off with a cover on it so it doesn't get pine needles in it, then I'm going to go ahead and try to take this wound dressing apart. And what I'm doing is slowly taking this material out and watching for bleeding. If I get a return of a significant bleed, I'm immediately going to repack and go back to pressure dressing mode. But most of the time, the body does a pretty good job when we got a good clot in there, and we're able to get that out and inspect the wound. I'm going to look for any foreign bodies, big chunks of nasty that got shoved in there that don't belong in there. They're just going to cause infection. Any obviously devitalized tissue, I'm going to try to remove. And again, that's a whole separate class. And once that's accomplished, I'm going to go ahead and take this water. I'm going to pour it from about 3 feet up, way high. After it's cooled off, of course. I'm gonna pour that down into the wound, and I'm gonna try to provide a little bit of cleansing, either with my finger or another object, other tool, to try to get any chunks out or other debris that's out of there and clean that wound up real good and get a good look at it and see what underlying structures are damaged. Once we've accomplished that, then I'm going to take this gauze and I'm going to apply it very loosely into the wound. I want to fill the wound. I don't want to leave cavities or pockets, but I want to get this down into the bottom of the wound and then pack it all the way up. Whereas before we were jamming it in with all our might. We're not doing that now. We're just filling the space with this wet dressing that came out of the water. We're using that moist dressing to pack it, cutting off the excess, putting a nice dry dressing over the top, and wrapping it. And we're going to repeat that about every 12 hours. If it's looking pretty nasty, we're going to do it every 8 hours. But you don't want to go any longer than about 12 hours because you're growing bacteria on that dressing. You're using, good point here. We're using the new dressing, not the old nasty one that we just took out. Right, very good. Okay, and so what we've done is we've packed the wound loosely and applied dressing. Over time, as that dressing dries out, it will adhere to any dead tissue. And when we remove it, it'll help pull that dead tissue out. It also prevents infection from pocketing and forming an abscess and becoming a real problem. If we're seeing signs of infection, things that can be done, we can take basically sterile water, bottled water, tap water if the municipal system's still working, or backpack filtered water, like run through the Catheter, and we can pump that through the wound as a continuous irrigation. We wind up doing that very, very slowly. It's just dripping into the wound through a little tube, and we wind up washing. That really decreases the bacterial counts. That's one trick for off-grid on trying to manage a wound like that. Another one is honey. Is a readily available thing typically. Honey is extraordinarily bacteriostatic and can soften any eschars or other infection in the wound. And so it is a well-studied, well-documented, austere technique, especially for burns as well. I use that on my own burns when I had burns as well. So when you're stockpiling for your home, one thing that I want to, I'll answer that one, David, good question. When you're stockpiling for your home, you want to have piles of Kerlex. If you think you got enough, you don't. It really goes through a lot of dressing material to manage a wound like this. A case of Kerlex is probably a minimum. A box of Telfa or non-stick type dressings is probably a minimum to be able to manage one wound. You're going to go through a lot of this stuff, especially with a burn. So honey, just put a little bit of honey in the wound and slap the dressing over the top of that. And then David asked about hydrogen peroxide. So if you want to mix a little hydrogen peroxide initially to try to get debris out of the wound and help loosen things, that's an appropriate thing to do. If you want to, usually about 50-50 is how we're running that, not straight peroxide, 50-50 with water. You can also use like a couple drops to a liter of dishwashing soap if it's something's really greasy and you're trying to get the oil or greasy residue out of the wound. That can help remove that. You don't want to use peroxide over and over again. It's an initial wound irrigant to get the big chunks out, but it is toxic to the tissues and it does slow down wound healing. And so it's not something we want to use. Another good question, silver in the wound, absolutely. This is where you're going to pull out your colloidal silvers and your nanoparticle silvers and all those things. Those are another good use of those types of products. Again, I'm not going to go into why they don't work when ingested, but topically, yes, they're effective at reducing bacterial counts. Again, my preferred is honey. Yes, there's lots of other substitutes, sugar, root crops. The list goes on and on. Broadleaf plantain, lots of different choices. Again, let's stick with what works the best, and that's what I'm trying to focus or highlight on. Sugardyne or sugar mixed with iodine or sugar, yes, can substitute for honey, but honey is the best choice if that's available to you. No, not a case of Celox, a case of Curlex. This stuff. You know, if you're going to get Celox, the hemostatic gauze, you know, get one or two, you know, depending on how many kits you're going to build. I think having a kit in your car is a really good idea because you're going to get hammered if you know, that's where you're going to get hurt in a car accident. So having a kit there makes sense, you know, within reach. And so that's that. Antibiotics make a big difference in this. You know, we're trying to minimize infection. That is our enemy. It's not enough time to teach it. It takes prescriptions to get it, unless you're tricky and you go overseas or go to the vet. Pain meds make a big difference. Again, lots of legal issues surrounding that. Suture capability. I teach an all-day class. We just don't have time to hit it in 40 minutes on suturing, austere suturing, how to improvise suture, how and where to sew, how to manage the injured tissue, specifically with debridement, tendon repair, how to cover bone, how to do the continuous irrigation in a lot more detail, and how to do a basic amputation if you have to. It's you know, if you can process a deer, you can do most of the stuff. It's not rocket science. I've included in the reference a couple of references here. One is Practical Plastic Surgery for Non-Surgeons. It's a free PDF you can download. It is a fantastic reference for wound management, and it is certainly worth downloading and having. That is the reference that I use when I teach my wound care or suture classes. Go down the top diagnoses that you think you're going to encounter: pneumonia, urinary tract infection, soft tissue infection, allergic asthma, or you know, those, you know, allergy type responses. Whatever you think those top 10 diagnoses are going to be, study them in detail. Take the time to read about them and read about the various treatments for them, and think about what you can and cannot provide for your family. Some really good references are also included here. And I put down the free PDF download link, as well as the shop on Lulu, where you can get a $35 copy of a book that I helped co-author. I'm not making a profit off of that. We all volunteered our time and published this book on austere and survival medicine.
It is available for free.
It's a free download, or you can get a hard copy. I think it's $35 or something like that to print it, somewhere in that neighborhood. And that'll really walk you through a lot of this stuff in a lot of detail, and a lot more. I'm opening this up for questions. Printed material to list in your kit. Pretty much it's the whole handout here. It goes through you know, tourniquets, Curlex, hemostatic gauze, chest seal, needle decompression, and then I carry a Foley catheter, and I'm not going to suggest that you should do that unless you've got specific training on how to do that, because that's not necessarily a benign thing. Yeah, I teach a class. Get with Michelle or Kenneth and out there in Utah, and if we get enough people together, then we could potentially set a date here in the spring. I can come out and teach a group. So what was the name of all that stuff for packing wounds? Yeah, it's in the handout, so it's going to be written. It's Curlex rolls, or your basic Kerlex. I think somebody threw a link, but you know, shop around, because there's huge price differences on Amazon. And you're also going to see things like you know, sterile versus non-sterile on Amazon. Again, non-sterile is probably adequate, actually, as long as it's clean, and you're going to save some money there. But sterile's, you know, better. But there's no such thing as sterility. The wound's not sterile. Your hand's not sterile. The area around the wound's not sterile. You're just trying to get it as clean as you can. The handouts are on this link here. I think it's going to be emailed to everybody. And let me just share screen real quick, just to show what you're going to get here in the email. So yeah, here's the overview email, and it just shows there's the IFAC, there's the tourniquet, Curlex rolls, hemostatic gauze, various chest seal brands, needle decompression. And then down here are the links for Practical Plastic Surgery for Non-Surgeons, And this is the download site here
You mentioned engineering.
for, oh, that's a good one too. This is the download site here for the Survival Austere Medicine book that we helped wrote. And this is the Lulu site right here of where you can get a hard copy of that for pretty low price. I think I sent Michelle also a, I sent a big giant PDF of engineering in emergencies, which is another fantastic reference for water and sanitation issues. It's a real definitive go-to guide. And so we'll make sure everybody gets a link to that download or a copy of that as well.
That's free.
It's free also. I see a couple other questions popping across here regarding honey, whether it's Meta honey, Manuka honey, it's honey. All right. It's just honey. You can go to the grocery store and buy honey. And that's exactly what it is. It's bee vomit. It works great. That's what we're looking for. Okay. If you go to KFC, it's not honey. Okay. It's corn sugar, which probably will help as well, but the bee vomit works the best. So, all right. And so, I hope that helps. Any other questions? I'm just kind of looking to see if there's any popping across. Michelle, are you seeing any questions?
No, there's some specifics about products and things I think you'll be able to answer better in a document answer Q&A. So
yeah. Okay. Well, again, that's the compression of the compression course. That's about as fast as I can skip over the top of this subject. I feel like we put one little small chip in the iceberg, but that's what I got.
Hey, thank you. So good. And really, I think that it gives everybody a little bit of an insight into what we need to know, what we don't know, what we need to learn. So.
The honey, the honey, people are asking about the honey here. I see it flipping across the screen. Again, I don't care if it came out of my beehive or it came out of Albertsons, it's honey. If it's been corrupted with other things, which happens with counterfeit stuff out there, then it's still going to work. It's just not honey. So, all right.